tip. And then that's not cardiac. Cardiac.
Ah.
We're looking at probably the highest yield point of care ultrasound test, I think, as an ER doc.
Oh, yeah.
So I do more echo than I do anything else in terms of doing point of care ultrasound. Maybe procedures and echo would be the top two. So chest pain, shortness of breath, and shock are the big ones.
Cool. Oh,
We
we're
lost
missing
our
a friend
friend.
now. Yeah.
We lost our friend, the curve probe.
All right.
So if it's all you have, you can use a curve probe.
Okay.
But if there's any other reason, use the phased array probe. There's a
Got
couple of reasons. Fits between ribs better, so you'll get less in the way of rib shadowing. And echo's really a game of millimeters and small angles.
Yeah.
So being able to get that advantage is huge. It's also, you'll never get a cardiac preset on a curved probe on any
Okay.
machine.
That's
They
good
don't
to
do
know.
cardiac presets. And why do you want a cardiac preset? It gives you more frames per second. So you'll see motion with a lot more detail with a cardiac preset. Even if you took this probe and you used an abdominal preset, it's going to look choppy and weird. And then when you put it on a cardiac, it'll look like an echo. So you really want a phased array.
Another pro tip for me.
All right. And then where do you put it? You basically look at the parasternal window, so just to the left of the sternum. You look at the subcostal window and the apical window. Okay. And I'm not going to go through exactly where to put this, which way the indicator goes. You should know that. There's also a lot of variation on it. But these are the core views we're looking for. So I think if you were going to be lazy and only get one view of the heart, and really in every patient, I think you should try and get a parasternal, a subcostal, and an apical, because you'll see advantages to each one, and some things will show up better in one view than another. But if you were in a hurry and you just wanted to quick look at the heart, you're busy getting ready to intubate the patient, do a bunch of other stuff that's relevant to patient care, and you just don't have time because there's too many other patients.
Yeah.
One view. And I've definitely only done a parasternal view on plenty of patients when I was in a rush. But what you're looking for is the left ventricle here, left atrium's here.
Okay.
You've got the anterior mitral valve leaflet,
Okay.
the aortic valve, pop it into view right there. That's a little bit of aortic root. The RV outflow tract, you just see a small amount of the RV.
Okay.
And then down here, the descending thoracic aorta
Cool.
Wow.
and the pericardium.
Okay.
So you can tell from this view, there's no pericardial fluid between this bright pericardium and the myocardium. There's a good overall contractility to the left ventricle. The walls are thickening and moving towards the center of the chamber with every beat. And the RV looks small. That's a lot of information in a sick patient.
Yeah.
Yeah.
Here's the short axis parasternal, where the LV should really look like a donut.
So this is where you just take the same personal view, but you just turn.
All you're doing is rotating 90 degrees.
Got it.
Okay.
So you're going from a long to a short.
Got it.
And if you want to think about what you're doing this way, you're basically just slicing like
Got it.
that.
Okay.
So here's RV, which will be small and kind of sitting on top of the LV septum, the interventricular septum, and then LV here. And the parasternal short axis really has a bunch of different sub-views. There's one at the apex, there's one at the mid-ventricle, at the mitral valve, at the aortic valve. For our purposes, most of the time, a mid-ventricular view is fine.
Okay.
This is the one that people probably started with. At least I know I started with it when I was learning a FAST exam when I was an intern.
Yeah.
And you've got liver up here, and then the heart deep to that. So this is a subcostal view. This is a great example of not trying to pay any attention to planes like we were talking about earlier,
Yeah.
right? Here the heart's deep on the screen and the
Right.
liver's on top of it.
That's right.
And that's because you're shooting from underneath.
Right.
Yeah,
And
super
it's just
weird.
not worth it. Just recognize that in a
Yeah.
subcostal view, the liver's on top.
Yep.
And in all of your views, except for the apical, where one chamber sits on top of another chamber, the top chamber is always the right side of the heart.
Cool.
It's always the RV, because the skin is closest to the RV.
Makes
Okay.
sense.
So this is right ventricle, left ventricle, right atrium, tricuspid valve, and pericardium. And then there's your apical 4. So left ventricle, right ventricle, left atrium, right atrium.
Okay.
Cool.
All right. And they won't give you any questions about tricking you into which side is the right side of the heart and which side is the left side of the heart.
Right,
so
right.
for the boards, you don't have to worry about that. Practically, there's a lot of ways to make sure that you're looking at the left side versus the right side, but I think for the purposes of this, let's skip it.
Okay.
All right, and then this one doesn't really have anything to do with the boards, but for emphysema patients who are hyperinflated,
Okay.
you can't get a parasternal window because it's all air. You can't get an
Got
apical
it.
window because it's all air, and their heart's sitting in their epigastrium. You can get your regular subcostal window and then just turn the indicator 90 degrees and get a short axis view of the heart, this 2-chamber view.
Is that a
So-
cigarette inside there? Or
It is. It is.
wondering if
That's, there's a cigar right there.
Oh, that's nice. Yeah.
And a little
And
baby.
a small,
Direct
small
access.
pericardial effusion as well.
And a gestational sac.
Got
This
it.
is a really
Gestational
weird
sac.
one. You know.
This is a cool one because, like you were talking about, people with COPD, they usually tend to be in respiratory distress, and you want to quickly figure out what the heck is going on. Is there COPD versus is it something like a
Yeah.
CHF that's exacerbated?
Yeah, like what am I looking for? What am I? So I'm looking for CHF. I'm looking for an effusion. I'm looking for what am I going to see there that I'm?
I mean, I think the big things you're looking for when you do an echo are, is there something going on here that's going to make me drastically alter my treatment plan?
Totally.
So is there tamponade
Yeah.
in this
Yeah.
giant effusion, or is there LV sitting there really myopathic, just wiggling,
right.
and all of a sudden this person's got heart failure?
Yeah.
And gone are the days where I think it was okay, like when I trained, to just give them some antibiotics and some nebs and some Lasix and some, right?
everything.
We'll just
Wait a minute,
treat
gone are those
everything and
days?
we'll let
Son
the
of a-
internal medicine docs sort it out. I mean,
don't wanna know that.
there are times where people have really challenging windows and you can't get an answer.
Yeah.
But most of the time you'll get a sense of, oh, wow, this heart's really hyperdynamic. I wonder if they're septic. They
Got
don't
it.
look like they're in heart failure.
Yeah.
And I think those are big things that you can tick off the list pretty quickly.
Got it. But chances are this is very clinically relevant, but for an
Clinically
exam,
relevant, but not on the
Got it,
boards.
okay.
Yeah, they will not give you a subcostal 2-chamber on the boards. It's just a really useful trick because you've already
Yeah, it's
got
cool.
the subcostal 4.
Yeah.
All you have to do is rotate 90
Yeah.
degrees.
Pro
So
tip.
it's not a new place to put the probe.
Cool.
All right.
Oh,
So here's your parasternal long. And this is a drastically altered treatment plan. So let's say this is your emphysema patient. Maybe they were told they might have a mass on their lung and they didn't really want to follow up and get chemotherapy. And now they're coming in short of breath.
Yeah.
And this is not their regular COPD exacerbation. They've got a large circumferential anechoic pericardial effusion. And yes, you can see some collapse of the free right ventricular wall here. I think for the purposes of people who are not expert in point of care ultrasound, your definition of tamponade should be there's a sizable pericardial effusion and the patient's really sick.
Okay.
And
Makes
don't
sense.
get too hung
I like
up
that.
on
Yeah.
RV free
Is
wall
that
collapse in
collapsed?
diastole versus right atrial collapse in systole versus transvalvular velocity and all this stuff. Just effusion plus sick patient equals I'm concerned for tamponade.
and for the exam, this is a classic image.
This is a
It'll
classic
be very
image.
obvious like
Yep.
this.
They will either, if they're going to give you a tamponade image, it'll almost certainly be either this or a subcostal 4-chamber with tamponade,
Yeah.
which
hard
will
to
look
miss those.
very similar.
Kind of looks like a dinosaur.
Stop it,
Dinosaur.
Paul. This is a learning experience. I feel like you're
Or a bear
totally-
claw.
Yeah. Everything looks like a donut to Paul.
It's true. So, again,
Yeah, there you go.
you know, you almost don't recognize chambers as you should when the heart's getting collapsed by this giant effusion. This is a complex pericardial effusion. You see that there's some internal echoes, not this strange artifact coming off the free wall, but out here, there's some echoes in it. This is hemopericardium in a patient with, I believe this was either post-procedural or an anticoagulated patient. You won't
Wow.
see, typically you won't see this big of an effusion in a traumatic hemopericardium. It accumulates really quickly and they tend to be smaller.
Okay.
Whoa.
Whoa.
It's like
That
a
fish
worm
is trying to get out, man.
Yeah. So this is the other reason why you do point of care ultrasound. Not that you're going to see this commonly, but you will sometimes be completely shocked and find stuff that that explains exactly what's going on. So this is a massive. It's not a PE yet. This is a clot
Oh my
in
God, really?
transit. So this is right atrium down here and right ventricle. And you get the sense that the RV is kind of big and not moving well,
Yeah.
but you do see this clot just kind of in and out of the tricuspid
Oh
valve.
my goodness.
So-
That's really impressive.
Thrombus in transit, or if you see signs of right heart enlargement and you're somebody who also does point of care venous ultrasound, you can often confirm a significant PE at the bedside,
Okay.
which is a great thing to do. They won't give you this on the boards either, but I think
that's
from
just cool.
from an echo perspective, I think the things you're looking for are signs of PE, signs of tamponade, and signs of LV failure. So those are the things
Cool.
that you're really going to try and
Immediately
get
that
to.
person has to stand on their head and hold their breath so that they don't push that.
Exactly.
No, don't stand on your head. Maybe, oh yeah, business. I don't know.
Yeah, so you're worried about planes again.
Yeah.
So
problem.
this is more common in terms of pulmonary embolism for clinical practice. Again, not necessarily for the boards, but your LVs here, your RV is bigger or at least as big
Yeah,
as
it's like
your
a
LV.
mirror image. Yeah.
And I would caution people against seeing a large RV and thinking that it's pulmonary embolism. Right. People have pulmonary hypertension out there
Sure,
from other reasons. They have sarcoid, they have pulmonary fibrosis. People have cor pulmonale from smoking for years and years. So seeing a big RV by no means equals pulmonary embolism. But at the same time, you get a patient who's really hypoxic, whose blood pressure is really low, and they're super tachycardic, and you look and their RV looks totally normal. It's pretty unlikely, and it'll at least move it down your list.
Yeah.
So keep in mind, lots of causes for RV enlargement, but that's one thing we do look for.
Great.
And then ejection fraction would be the other thing we're looking for. And I don't think as a new user to point of care or even an experienced one, you necessarily need to come up with a number and say this person's EF is 80%, it's 70%, it's 60%, it's 50%. But you look at this, and in this apical four-chamber of a stab wound victim, they are incredibly tachycardic and also hyperdynamic. The walls are coming together and touching. So that's like 100% EF.
Interesting.
As opposed to somebody with bad myopathic heart failure. So this person has a dilated cardiomyopathy, and you're looking at a short axis view of their LV here, and it's just barely moving. The walls aren't thickening. They're not moving towards the center of the chamber with every beat. And this, to me, was probably what hooked me on using point of care ultrasound a lot in the ER, was these short of breath, hypoxic patients who'd come in respiratory distress.
Not quite sure.
You'd look and see this, and then you'd look at their lungs and see pulmonary edema, and in the space of 30 seconds, you know exactly what's wrong with them. Which this is really, I think, a core skill for emergency physicians.
It's awesome. It's like you said, you don't need to quantify it. It's a good squeeze, bad squeeze.
Yeah. And if you find yourself pretty much across the board in point of care ultrasound, but if you find yourself wondering and trying to talk yourself into, is it a gallstone? Is it not a gallstone?
Yeah.
Is it a normal EF? Is it a low EF? Is that an effusion or is it a fat pad? Is it perinephric fat or is it fluid? Don't make a decision clinically on it. Order the test that you would order if your ultrasound was broken.
Right.
Right? That's where I see people get into trouble with point of care, is they try and force the diagnosis, or they're kind of just, it's probably this.
Right.
So if you're confident, it's a great tool, indispensable tool. But if you're not confident, don't use it. All right. And here's a good example. So if you look at this subxiphoid or subcostal view, you could convince yourself that that was fluid in the pericardial space. And I'll tell you, it isn't fluid. It's a fat pad. It's a epicardial fat pad. How do you know? Well, it's not circumferential. It's limited to this area. It's also got small internal echoes that move with the RV free wall, and that's subtle. And this is a great example of, I'm not sure if there's an effusion or not if I'm a novice user. So if you're concerned about it clinically, get an echo on the patient.
Okay.
Right?
Makes sense.
And then just another pitfall that I've definitely seen a bunch of times, especially in trauma, is you've got, let's say, a stab wound to the left chest, and here's your parasternal long axis view. There's the descending thoracic aorta, and you've got this fluid here, and you've got this fluid here. So pericardial fluid is going to track between the descending thoracic aorta and the heart. So that's a small pericardial effusion.
Okay.
But then this is a huge pleural effusion.
I see.
Cool.
This is a patient who doesn't need to get rushed to the OR for a window. That's a tiny effusion. They need to get tube thoracostomy.
Yep.
All right. So just make sure you know if you're looking at pleural versus pericardial. And the one kind of pearl I'll give you on it is, if you're really not sure, get that view of the left upper quadrant like you did for a FAST.
Oh,
Because you're used to looking at pleural fluid
Yeah,
like that.
so you can
And if
see
you
where
look
you're
and you
at.
see it layering above the diaphragm and there's the collapsed lung, then that really helps you. And if you look and you don't see anything there, that's going to raise your
Got it.
suspicion that
That
it's
makes sense.
pericardial.
But the key for this is your reference point is always going to be the descending aorta.
It's right there. So just
it.
behind the left atrium is your descending thoracic aorta.
Nice.
And if the fluid goes over it, pericardial, deep to it, or stops at it, is pleural.
Cool.
And then what do you guys think about the ejection fraction here?
It's not going to the center, the distal part, the apex is, but the proximal mid portion.
So by your scrunched faces,
Yeah.
I just want to drive this home. Don't make a call.
Yeah, I
this
can't-
is
I was
the
gonna say, I wanna say
moderately.
good or
This is
bad.
a moderately depressed EF, but these can be really hard. So
Yeah.
the people with the EFs of 45, and right over 55 is normal. So
Yeah.
the under 30s are easy. Those are the ones that don't
Yeah.
move at all.
Right.
But in the middle, people get hung up. So it's okay to kind of move along and defer judgment if you're not totally certain. They won't give you that on the boards.
Yeah.
And so we'll move on from that.